Thanks for having me today. I'm Brad Icard. I work at Cone Health, part of LeBauer Pulmonary, and our crew is kind of sitting over here on the left side. So I was asked today to talk about lung cancer screening, and I kind of wanted to focus it on the armamentarium and the data and the things that you want to know about lung cancer screening that you can take to the community. And Cone has a healthy communities focus as one of their metrics and things that we're trying to do for the healthy community, and lung cancer screening, I think, is really important part of that. So just a few disclosures. I do have a work for principal investigator for a couple of trials. I'm going to tell a little bit about my story, and I'm going to tell you why I got a big plane up here. So lung cancer has probably affected most everybody in the room in some way, right? And we've all been, Jim this morning telling us a little bit about everybody's stories, and I'll tell you about mine. But really my first interaction with lung cancer, and I'll tell you this about a patient. He was 57. He was a short, round, kind of rotund, jolly gentleman. He started losing weight, was put on new medications for his diabetes, had lost about 30 pounds. He had quit smoking when he was 38, when he found out he was fixing to have his first daughter. And so he quit smoking at that time, and now he's 57 and was losing weight. And so ultimately getting a chest x-ray. Chest x-ray had an incidental finding on that, said he had pneumonia, never got cleared. Never had a repeat chest x-ray after that, come to find out, to see if it ever went away. Ultimately ended up getting CT imaging, found to have a lung mass, adenopathy within the chest. He had pelvic bony lesions, spinal lesions at the time of diagnosis. It took almost 8 weeks to see a surgeon to get a biopsy done. And that required an invasive procedure. He had an anterior Chamberlain. If you know what that is, that's an incision on the anterior chest that requires cuts and incisions, right? Something that wasn't minimally invasive. He, at that point, had become pretty deconditioned, had a surgical site infection because of this surgery. It's the first time I ever learned about MRSA and wearing plastic gowns. This is before I was in medical school. He got palliative radiation treatments, and he unfortunately passed 2.5 months into his diagnosis of stage 4 adenocarcinoma. Now, that's important to me because that's my father-in-law, and that's my wife's dad, and we weren't married yet. So we moved up our wedding day so he could be a part of it. We had 2 weddings. Married the same woman twice. So I had to really stick. So I think it was just his way to make sure it really stuck. But when I think about his story, and I think about what myself and the team at Cone Health are able to do now, I recently had a separate patient, also 57, enrolled in our lung cancer screening program because she also quit in her late 30s, scanned every year. 5 years in, she started at age 52, at age 57, now had a new, or 58, I think, had a new nodule, looked like stage 1 malignancy. She came into our hospital. We did a combined robotic procedure where she has a biopsy done by me. She stays asleep. We confirm malignancy in the room. She goes from my table to the operating room table for thoracic surgery, has it resected, stays in the hospital for 48 hours, and leaves cured from her stage 1 lung cancer in one event, right? And so I compare those 2 stories and understand the importance of lung cancer screening that's associated. But this is a Boeing 787, I think. Roughly carries around 380 some people at a time. But the daily U.S. death from lung cancer would be no different than a 787 crashing on U.S. soil every day, right? Think about that, right? It's a lot of people. That would be on the news, right? It wouldn't be a nightly news session that we wouldn't hear about another, we'd be grounding flights, right? Nobody would be getting in the air if we lost that many patients a day. But more importantly, what about lung cancer here? And when I say here, I live here. This is my home. The Triad is our home. I'm originally from Western North Carolina, but when you look at lung cancer, of course, we all know it's the number one cancer-related death. Kills more than colon, prostate, and breast. When you look at Guilford County, which is the little square in the middle, or the rectangle in the middle, and the 8 surrounding counties, in that location, it's about 20% of lung cancer in the state is diagnosed here. So about 18% of lung cancers in the state are diagnosed in what I consider Guilford plus 8. So the G plus 8 region is about 18%. Roughly 1,500 new lung cancer diagnoses a year, and between 2015 and 2019, 40,000, right, across the state. And you look at the mortality rates and the incidence rates of lung cancer, of how high they are in some of our separate locations. Rockingham County, our neighbors to the north, Guilford County, Alamance County, and Randolph County to the south. And when you think about incidence, that's like the number of people that have cancer per 100,000 in population. In 2021, U.S. Preventative Services Task Force changed recommendations to do 50 years old to 80 years old, greater than 20-pack year history of smoking, quit smoking within the past 15 years, right? So it's not somebody that's actively smoking. There's sometimes confusion there, right? So it's people that have quit too, are still eligible for lung cancer screening, and that's a low-dose CT. And the story about my father-in-law is important to me because that year was 2009, right? The National Lung Cancer Screening Trial, the NSLT, came out in 2010, right? So it was before we even offered lung cancer screening, right? So the number of lives that we could have impacted even years before that are important. So things you need in your armamentarium, people see these words and don't know what they mean. What does pack years mean? It's pretty simple. It's just the number of packs of cigarettes a person has smoked times their years that they've smoked it, right? So 2 packs, 10 years, that's a 20-pack year history. However else you want to do your multiplication, that's to help people out there. Now think about these things. I'm going to give you 2 sides, some more data-driven stuff, and then what the community really needs to know about. But you think about benefits of lung cancer screening, right? It's early detection, right? We've got we got multiple different lenses in which people view lung cancer and how it's affected their lives here today. Some are folks that have never smoked, right? And how do we work on screening those? We'll talk about that in a little bit. But near 80+% of our patients are affected by lung cancer because of tobacco use. So higher detection rates, higher probability of resection and cure, right? And we'll talk about those numbers too. But the overall 5-year survival rate, like we've talked about, is still low, about 22%. And maybe it's up a little bit more with the recent data that came out. But screening saves lives, early detection's key, and 1 out of 16 are affected, right? We talked about that earlier this morning. If you got lungs, you can get lung cancer. And I'll pick on Dr. Muhammad since he's sitting over there. But if I do my job right, they don't have to see him, right? Right? If they end up in an infusion chair, that means we could have caught it 5 years ago, right? So what are we doing about that, which saves some of the impact and heartache that the patients are going through receiving treatments for those things? That doesn't mean it comes with other things. Right? It comes with having a surgery. It comes with having other interventions. But there's harms that comes with screening. People have experienced those too, right? Anxiety, unnecessary tests, right? When a provider or physician, APP, you order something for a patient, we sometimes find other things, right? That's also the hesitancy that people have with getting screening. I don't want to know, right? I hear that all the time. Patients, say, well, why don't we send you for a lung cancer screen? I don't want to know. Like, what do you mean you don't want to know? Right? You have this conversation like, well, you get your mammogram every year, right? You have cervical cancer screening every year. But, they have that connotation, or somebody said it earlier in the audience, it's my fault. Well, it's my fault. I don't want to know about it, right? There's a stigma that's associated with lung cancer that we have to break. And the people in this room are the folks that are going to be able to break that in the community. And so that's important. There's false positives. I'm going to get into the stats thing if you don't like stats, but there's false positives, when you find things, not all lung nodules are malignancies, right? And you got to be able to have that discussion with a patient. Tell them it's going to be okay. We're going to repeat your scan in 6 months. That comes with anxiety, right? That's what I do every single week in clinic. I was in clinic all this week. I probably saw 80 people this week. And every other one of them is usually a lung nodule. And we're talking about, we'll get your repeat scan. We'll follow this up. And you've got to be able to supply some of that reassurance to the patient that if it changes, I always ask people, when I walk in, I usually say, are you behaving or misbehaving? And they look at me like, what are you talking about? I wasn't talking about you. I was talking about your CAT scan. I haven't looked at your CAT scan yet, but is it behaving or misbehaving? And the patients have picked up on it. They know my lingo. And we want to know if it's misbehaving. I mean, did it get bigger? Did it grow? Did the morphology change? Does it look different? Those are all warning signs for me when we're looking and following sub-centimeter nodules. So the message to the community, sometimes we actually find things and we don't know what to do with them, right? We don't, as providers, even now, sometimes find small things on CAT scans that we have to tell patients, I'm not sure what to do with this yet. I don't know if it's a cancer. There's a risk tolerance that's associated with that, right? I have some people that are very risk adverse. They're like, Doc, can you scan me in 3 months, right? Can you scan me in 6 weeks? Is it going to get bigger? I just got to know. And there's other folks that may be like, it's fine. We'll look at it again in a year. But you got to talk to them about that. You got to give them that piece of information. And remember, not everything in the chest that looks abnormal on an image is a cancer, because everybody's brain immediately goes to the worst, right? So you got to be able to talk them off of that ledge. And of course, that creates anxiety. Underutilization. That's one of the biggest things that we battle with lung cancer screening. Only 8% in North Carolina of the eligible patient population is screened. So that means we have 92% opportunity. Right? That's the best way to think of it. We got better options for that. There's a higher probability in the uninsured population of not getting screened. Right? That makes sense. Because they're not going to do it or not afford it. There's REACH grants and all the kind of other stuff that are out there, even with LCI helping fund lung cancer screening for that uninsured population. But 15%, people of color are 15% less likely to receive an early stage lung cancer diagnosis. Right? And so what are we doing to help change that disparity and having access to lung cancer screening? The message is that we can do better, right? We can, lung cancer screening is the lowest rate of cancer screening that's out there when you compare that to mammograms or cervical cancer screening or colonoscopy, all of those kind of things. There's a stigma, and then we got to break it. And we need to do something about our healthcare disparities and making sure that every population that's out there is eligible and understands what we can do and how it can save their life. Most people don't know these numbers either. I think they're very impactful. But when you think about stats again, there's something called number needed to treat. Calculate that, it's actually 1 over the absolute risk reduction. I won't get into the details. You don't want me doing that either. But if you extrapolate, if you change that to what's considered number needed to save a life, right? So the estimates, when you look at large studies and clinical trials for the utility of that, it takes about 1,000 or so colonoscopies, plus or minus, to save a life. That means if you get, 1,000 45-year-olds that are eligible for cancer screening with colonoscopy. If you did 1,000 of them, you would find one person that you could, impact their cancer that would save their life, right? That's kind of how they calculate that number, if I'm breaking that down correctly for you. Mammograms, roughly about 900 to save a life. Lung cancer screening is the most effective form because we are targeted to a high-risk population. We're already taking this big group of people and boiling them down into a funnel and then looking in that high-risk group. It only takes about 320 to save a life. I've shown this picture a couple of times. I've even shown it to some administrators. I always let them choose, which lung cancer do you want? One call I was on, there was like 19 people on the call, and I said, that's great, because I was like, one of us is going to have lung cancer. They were like, what are you talking about? It's like 1 out of 16 gets lung cancer. There's somebody on this call, statistically, is going to get lung cancer. Pick which one you want. Complete radio silence, right? Because up until recently, we were not able to do anything for a lesion like this on the far left side, right? Most health systems don't have the ability to do something to diagnose a lesion that's less than 10 millimeters in size, right? It takes a lot of equipment to do that. That's what I do for a living, is go after things that are less than 10 millimeters in size. But to be able to do that, that's what we offer for patients, greater than a 90+% 5-year survival rate. Right? I don't want to catch it when it's on a chest x-ray on the end, right? These are all stage 1 lung cancers, right? These are all stage 1 lung cancers. But based on size, they all have a different 5-year survival rate, right? We need to focus on internally stage shifting. That makes sense? Not just thinking about taking people from stage 4 disease to stage 3 disease, not taking people from stage 3 to stage 2 disease. What am I doing about taking people from T1C disease to T1A disease? Because if we catch it like this, we can get rid of it with the help of our surgical colleagues. Sometimes if they're not surgical candidates, our SBRT, people that get radiation therapy, radiation oncology colleagues. So 5-year survival rates, right? T1A, 92%, right? But unfortunately, most people in the community, they're in that central column. People diagnosed outside of screening programs. These are this was studies that was done with every little head counts as like 100 patients. So majority diagnosed at stage 4, 3, and 4 disease, about 60%. When you compare to them inside of a screening program, we invert that. Right? We're screening people, and doing that, we find more stage 1 lung cancers. If we find more stage 1 lung cancers, we can find more people on the far left column. These are all my patients. But what does lung cancer screening look like? Right? It's painless. There's no injections. It takes 10 minutes. Right? But we got to tell patients that, right? What they don't want to deal with is having to deal with what we find, right? Most people are fine with getting it done. They're just scared about what we're going to have to tell them, right? And we got to make sure we tell them things that we are able to do this, right? How much radiation? I get this often too. This kind of gives you a little example of where we're at. So it's about was it like a 12, 13 hours? I don't know, a couple hours on an airplane. More, that's a 10-hour flight, so it's still more than that. So a couple of flights a year, roughly, about the same level of radiation. Okay, but obviously much less than almost sevenfold difference than a regular diagnostic CT. So here's our non-smoker risks. I had a lady I was just telling Paige about. She lost her mom and her dad within a 6-week time frame of malignancies. And her mother had adenocarcinoma of unknown primary and non-smoker, and she's in her 40s with 2 kids and just trying to absorb all of that. And she wants to know, what can she do for screening for malignancies, right? There's a couple of companies out there right now that are working on blood testing for high-risk malignancy work. Being able to look for, free tumor cell DNA and other kind of things like that would put people into categories, which maybe we can use one day. So there's people out there working on it. I try to talk to patients about their risks, right? So second leading cause, radon exposure in the U.S. Occupational history is important. Exposure to secondhand smoke, air pollution, do they have other underlying diseases, interstitial lung disease, IPF, et cetera. Those are all things that are associated with that. Genetic predispositions, probably the youngest person I've seen with lung cancer was an 18-year-old female that was diagnosed in a college chest x-ray she was planning to run, I guess, a track or something for college, and she had a chest x-ray done before going to school. Totally asymptomatic at time of diagnosis, but she was Asian female, high probability for EGFR mutated malignancy. And so that's what she had. So, so there's other reasons to get it, right? Not just cigarette use. Radon exposure, it's from the environment, right? People don't know about it, but it does exist. So having your home checked, I think that's a pretty cool number there. 200, if your radon levels are greater than 4 in the house, then that's roughly 200 chest x-rays a year or 8 cigarettes a day. Right? It's almost a half a pack a day. So, there's options for that, having it checked, having a fan installed, and there's lots of information available online and CDC. We recently just crested 1 million being screened into the American College of Radiology's registry, or the ACR registry. And so the sad parts that I want to bring out about it, the trial only showed that we had 22% adherence rate, right? So out of those 1 million people, we only got 22% of them to come back to have their scan done. Of course, it trickled based on 3, 4, 5 years, but they'll do it once sometimes. So we've got to be just as passionate about having it done one time as we have the next year, right? So how do we make sure that patients are engaged at staying in the program, right? So something that we're working on, and I think is pretty awesome, this is our lung cancer screening numbers. Moving forward, year to date, this is probably July's numbers on the bottom table, but we're probably going to hit about 3,500 screened this year, which is pretty awesome. And then our stage 1 lung cancer diagnosis rates up through last year. So we're continually seeing a % increase of our kind of own little internal stage shift. Right? We're seeing more people that we're able to diagnose at earlier stages. And something that we're working on here at Cone and in our community is, what can we do to streamline this process? How do we get people from our lung cancer screening program? How do we get people from our incidental nodules, right? One of my favorite stories about diagnosis of a lung cancer, and the gentleman I still see today, he lives kind of Southern Virginia and drives down, but he's riding his Harley through town, and this lady was on her phone, not really paying much attention, and the dog was over here. He didn't think anything about that, but there was a cable, right, associated with that dog that was across the street. Well, he got clotheslined by a dog cable while he was riding the Harley, right? So he wrecked his car. He was fine. He did okay. He went to the ER and got scanned and all this kind of stuff for trauma. But now that he blames that dog for saving his life, because because he would have never known that he had a lung cancer, had quit smoking 20-some years before, and now he's doing well, recovered from that. So that it's what do we do with these incidental nodules? How do we manage them? How do we do it better, faster, right? At Cone, we've probably done about 65 or so, almost 70 single anesthetic events for people that are high risk. People that come in that I tell them all the time, you got a lung nodule, it looks like a duck, quacks like a duck, it's probably a duck. So we're going to move forward with plans of high-risk people for surgery. So how do we get those folks into the win column for cure? So thanks, everybody, for listening to me today, and I'll take any questions.
It's my first year attending. I hope to be first of many here. Thank you, Lung Cancer Initiative, for the invitation. But you did kind of put me in a bind. You gave me 30 minutes to talk about all of lung cancer treatment. So I'm going to do my best. I can tell we've got an engaged room, and I want to leave time for questions. Bradley did a great job of talking about statistics. It's mind-numbing. It doesn't matter what statistic you want to choose. I think everybody here knows just how dire things are, and that's why we're all here, because we want to make sure everybody else knows and understands just the size and the magnitude of the problem. And what I wanted to do was walk you guys through how did I decide to be a lung cancer oncologist. This is what we're going to cover today, and it really kind of covers my life story over the last decade or so. So just a few historical perspectives, and then kind of the two big topics in lung cancer, targeted therapy and immunotherapy. We'll talk a little bit about what's coming, and like I said, I want to try to save time for questions. Paige, if I'm running behind, give me a cue, please. Okay, so Mohammed, you remember this study, I'm sure. This is a study that was published in 2013. That's 10 years ago, okay? That's when my grandfather was diagnosed with lung cancer. I was a resident. And I hit the internet and said, what are we supposed to do about this? This was a much heralded study. We finally knew that by giving maintenance therapy, whether it was bevacizumab or pemetrexed, we were going to make a big difference. And you don't need to know what these curves are to see what the picture tells you, which is that it didn't move the needle at all. This was a huge letdown in the lung cancer world. If that's where we had gotten to, I wouldn't be up here today, because there wouldn't be very much to say. The 2-year survival you can see there for these patients, and these are the healthiest of the lung cancer patients that could participate in a trial. Only 1 in 4 were alive at 2 years. Thankfully, we have a lot better statistics coming. So when I started my training, I was told there are 3 pillars of cancer care. You have surgery been around the longest, radiation, and then the medical oncologists were the new kids on the block. And that every person that had cancer, your only options were to combine these 3 treatments in different ways, depending on the type of cancer and the stage, and that was the best you could do. And thankfully, that's not the case. Targeted therapies, immune therapies. This says they've been around since the 1990s. I think in the clinic, they've really been around maybe since the 2000s, and in lung cancer, thankfully, in the last 5 or 7 years, we've seen an explosion of targeted therapies. And then, of course, immune therapy. If you have a television, you've seen advertisements for Keytruda and Opdivo and things like that, and with good reason, because these 2 pillars in particular were blessed in lung cancer, which sounds weird, but it's true, that both of these are applicable in lung cancer today. And so we'll cover some of that data. So this is part of what I talk to patients about when I'm talking to them about sequencing their tumor. A lot of them don't, they kind of get hung up on, why do I have these bad genes? Why are they there? For some of them, why did God put them there, right? And I have to explain to them, they're not inherently bad. So an oncogene, it's just a growth gene, right? And under normal circumstances, it responds to the body. And the body says, cell, you need to grow. And so it helps the body or the cell grow. But that growth gene can be changed. That's what a mutation is. It's just a change in a gene. And if a growth pathway, a growth gene is mutated into a way that it can't be turned off, that by itself can transform a normal cell into a cancer cell with no good reason, without smoking, without radon, without anything. And we've known for a long time that there are patients that this is what's causing their lung cancer. EGFR, one of the very first genes that we understood can cause lung cancer. The G stands for growth in EGFR. A second group of important genes are called tumor suppressors. Okay, these are kind of the opposite of oncogenes. They tell cells to slow down. They're telling cells not to grow, right? And so if you have a change or a mutation in one of these genes, you're losing your brake pedal, right? We use this gas pedal, brake pedal analogy frequently. And so this is all well and good. It's nice to know this. Some of you guys aren't as interested in science as me, so you probably think, well, who cares? But the Human Genome Project really changed the game here. Our ability to sequence DNA changed dramatically. I remember I was pretty young at the time. I'm not going to date myself by telling you how old I was when it was published, but I remember watching, my parents sat us down and we watched, some news clip about the Human Genome Project. And it was, hundreds of scientists that had worked for a decade to sequence the genome of one cell. And it was a huge accomplishment. And now in clinic, every day, we're sequencing the majority of a cancer cell's genome in 3 weeks. It's truly astonishing the rate at which the science has allowed us to drive innovation and better outcomes for these patients. I don't expect anyone to memorize this. I certainly haven't. But what we're looking at here are pie charts of all the different types of changes in the DNA that we see in people with non-small cell lung cancer. The reason this is important is because these genetic alterations are mutually exclusive, meaning that if you have one, you don't have another, right? And on the right, you're seeing a group of patients with metastatic non-small cell lung cancer. And these patients all had the deepest genomic sequencing that we have available to us. And you can see that almost every single one of them, we identified a gene that could be considered the culprit for how they got lung cancer in the first place. So until we had things we could do about it, this was irrelevant. This was nice for scientists to understand and to know. But in the last decade, we finally started getting treatments that could exploit this. We hear politicians talk about curing cancer, and I would love to be out of a job. And that's what I tell patients. It'd be great if I never had to go to work again. But at least in my experience, in order to cure every single cancer, we'd have to find some sort of molecule, pathway, protein that every single cancer cell had, every single cancer cell could not live without, and that no normal human cell had. If you found that, every treatment that we designed would target that one thing, right? Chemotherapy is the opposite. Chemotherapy is drugs that kill fast-growing cells. That's part of the reason why chemotherapy has a bad reputation, because we know that when you give chemotherapy, there will be certain side effects that you experience. But that's the spectrum. Chemotherapy here, hypothetical cure for cancer here. These targeted therapies are here, right? Cancer cells that rely on one of these oncogenic driver pathways, they need that gene 10,000 times more than normal cells do. So if you target that gene successfully, you can effectively, preferentially kill the cancer cells and spare the normal cells. And that's where we've made a lot of progress in the last decade, is in the targeting of these oncogenic genes. So when I started in fellowship, I remember an early lecture where, I was interested in these patients because of what my grandfather went through. And I thought, well, I wonder if he could have had one of these, right? He died before any of this testing was commonplace. And I thought, well, maybe he did. And this is what I was told. Well, you got to be young to have one of these genomic drivers. You can't have ever smoked. More often than not, you're Asian, female, your histology should be an adenocarcinoma, and you often have brain metastases. And this was somewhat of an unwritten rule. It was, don't even bother testing anybody if they don't fit this profile, because there's no point. So this is who came to mind. She, I've not seen her walk into my oncology clinic yet. I don't anticipate I'm going to, but this is what I was told as a fellow not that long ago. And so, I tried to, listen to my professors, but I also thought, I'm not so sure about this. This is a really seminal publication, the FLORA study, looking at osimertinib in patients with EGFR mutations. And, you don't have to be, the smartest scientists in the world to just look at the publication and see what it tells you. What's the median age of these people? 64 years old, right? I mean, for some people, I guess that is young, but I don't think as young as my professors wanted to make it out. There's a female preponderance, but still, almost 40% were male. Yes, there was, more Asians than Caucasians. This is probably the biggest one. More than a third of these patients had smoked. And I think that's probably the number one myth, is that you don't need to do this testing in people who have smoked because they can't have it. And it's just not true, especially where we live. They do mostly have adenocarcinomas, and brain metastases are common. These targeted therapies, when we get them correct, are incredibly efficacious. So what we're looking at here is called a waterfall plot. I had a separate slide with some other information. Maybe I can get that to you guys after the fact. But this doesn't really look like a waterfall, right? If it did, it would be a pretty unimpressive waterfall. But what you're looking at is the dotted line there, the solid line. Each individual column is a patient, right? So each one of those blue and light blue and dark blue lines is one person. They all start at 0. That's the day they start their treatment, okay? If their tumor grows, they go up above 0. If their tumor shrinks, they go down below 0, okay? So what you're seeing here, and these are people with RET mutated non-small cell lung cancer, is when they started their pill, almost every single person's tumor shrank. Targeted therapy before this, the plots didn't look like this. Half the people's tumor would grow, some would shrink. The people all the way on your right, minus 100, that means remission, no signs of cancer. This is a pipe dream for oncologists for a long time, but this is now the reality, is that if you find this person and you get them on the appropriate therapy, you can change somebody's life. Here's the approvals for all the different targeted therapies in the last decade. You can see the different colors. So these are the different genes that we can target. And if you go back to 2013, 2011, EGFR and ALK, that was it. We couldn't target anything else. We knew these other genes were growth genes, all the other genes in the pie chart. We knew about them, but we couldn't do anything about them. But then as you go from 2014 to 15 to 16, et cetera, you start seeing different colors popping up, right? You see the gray for ROS1, you see the orange for the BRAF gene, you see the red for the RET gene, et cetera, et cetera. This is an astronomical rate of drug development for one disease. We've never seen anything like this. It's a real challenge for the medical oncologist to know all these different drugs and their toxicities and to deliver them to people. But the important thing to understand is that if you don't test, you're never going to know. And if you decide in your head who has it and who doesn't, you're going to miss people. And unfortunately, some of the other therapies we give when someone has one of these driver alterations don't work. So for those in the audience, if you know of someone that's dealing with lung cancer, they need to ask their medical oncologist, have you done a tumor sequencing? And if they haven't, they need to push back. And they need to say, no, this is really important. We need to get that done. The KRAS gene in particular, I recall in training, I was told is non-targetable. We've tried, you can't do it. Here's some of the press releases. Undruggable KRAS, from undruggable to druggable. Targeting the undruggable, there's hundreds of these. Because for a long time, anytime we tried to target KRAS, it didn't work. And as you can probably guess, that's not the case anymore. KRAS is a very commonly mutated gene in cancer. Doesn't project very well, but almost 2/3 of patients with pancreas cancer have a KRAS mutation, 1/3 of colon cancers, and 1/5 of lung cancers. So right off the bat, you know that this is a gene that makes a lot of sense to try to target, but as I told you, for a long time, we couldn't do it. And then that changed. This looks a little bit more like a waterfall, but still, what you're seeing here, this is called code break. This is a pill that just recently got FDA approved within the last couple of years based on this study. Again, the vast majority of these patients starting at 0 had their tumors shrink. Not everybody, but this is certainly something that represents a huge amount of progress from what we had seen previously. And as a result, you can see this very long list of studies investigating this agent in combination with tons of different other approaches, whether it's other targeted therapies, chemotherapy, immune therapy, et cetera. All right, so what do we know about these patients that have driver mutations? They don't have to be young, right? Anyone a fan of the show Mythbusters? Anyone seen that? Yeah. Certainly they can have smoked. They don't have to be Asian, and in particular, BRAF mutations, often present in smokers, often in Caucasians. Don't have to be female. It's true that they're mostly adenocarcinomas, and it's true that there's a high degree of brain metastases, but if you're only looking for Lucy Liu, you're gonna miss those two. And they may be the ones that end up with the driver mutation that you didn't catch. All right, so switching gears entirely here. Immune therapy. Durable remission, lung cancer remission, those words didn't go together for a very long time. I thought about excluding this slide because I don't want to give surgeons any more credit than they're due, but Dr. Coley is probably the pioneer of immune therapy. He was a bone surgeon in the late 1800s. I can only imagine what that looked like. But he observed that when his patients got infections after he operated on a tumor, some of their tumors would go away. And he said, that's interesting. And there was, no FDA or anything like that back then. So he said, well, I'm just going to inject some bacteria into these tumors and see what happens. And it worked for some people. And he called this Coley's toxins. And this is a clipping from the New York Times that I really love for a lot of reasons. But germs as a cure for cancer. Dr. Coley's remedy makes one disease cast out the other. Many cases cured. Physician has used the cure for 15 years and treated 430 cases, probably 150 sure cures. Turns out reporting hasn't changed that much since 1908. Yeah. So this cartoon here at the bottom, the evolution of man, here's where Dr. Coley is at this point, right? Okay, so a little bit of basic immunology. Funny enough, that was by far my least favorite topic when I was in med school. I failed horribly in understanding it, and now it's probably the most important thing that I do in clinic every day. I try to oversimplify things. It helps me understand it, helps me explain to patients. Lymphocytes, right? These are immune cells. They come in B and T cells. The B cells come from the bone marrow. They make antibodies, right? We've been talking about antibodies a lot during the pandemic. The T cells come from the thymus. They're part of the cellular response system. Their job is to go through the body, and every other cell they encounter, they say, you're a part of this person, I will leave you be. You're not part of this person, we're gonna get you killed. It's more sophisticated than that, but you'll see why I'm explaining it that way. So PD1, PDL1, right? Most of us have heard what that is. Again, similar to the genes, EGFR, P53, PD1 is not bad. This is not a bad pathway that's there. In fact, your normal cells need ways to tell the immune system, leave me alone. I'm supposed to be here, right? You've heard of people with autoimmune diseases, right? The immune system makes mistakes. So the normal cells want to be able to tell the immune system, I'm good, don't kill me, right? The problem with this pathway is that cancer cells are really smart and they co-opt this pathway, right? The only thing your body already has in it that can kill a cancer cell is your immune system. They are natural enemies, right? So it makes sense that the cancer wants to hide from the immune system. That's the only threat to it in your body. And so it sees normal cells using this pathway, and it copies it, right? And so in some people, even if the immune cells have gotten to the tumor, they're sniffing around, they say, something is not right here. They get this off switch from the cancer, and they don't do anything. They just sit there, right? And so this is the target of the majority of the immune therapy drugs we have today. And you can see there on the right what this does. The analogy I give to patients, it's like pulling back the curtain and saying, immune system, by the way, there's a cancer here. Please fight it. So when you block that signal, the immune system can wake up and attack the cancer, right? Nothing to do with fast-growing cells being killed. And the reason this is such a big deal is because of what we've seen when we give these drugs to people, right? This was the game changer. This is right as I started my training, Keynote 24. It's published in 2016. You know, when immune therapies first came out, there were some successes. People have heard of the Jimmy Carter drug. You know, melanoma was a lot of early wins. But a lot of other cancer types, the first trials of immune therapy failed. And so there was enthusiasm, and then it kind of fell flat. And they said, you know, immune therapy, these drugs are nice, but they're, you know, they might add a little bit, but they're not it, right? But the problem was we didn't understand who to give them to. We just gave them to everybody, right? And this study said, well, why don't we restrict who we give this to? That PD-1, PD-L1, we measure that in everybody's tumor. And they said, well, if you have a lot of that in your tumor, since that's what the drug targets, you should probably respond to one of these immune therapy drugs. So they said, all right, what we're going to do is give the strongest chemotherapy we've got versus one immune therapy infusion. It's a very simple infusion, 30 minutes every 3 weeks. And we're going to see which works better. Pretty bold to go after, you know, something like this. And what you're looking at is the blue is the people that got the immune therapy, right? The red is the people that got the chemotherapy. I didn't highlight this, but you remember the 2-year survival rate from 2013, 3 years before this, was 25%. You know, the 2-year survival rate for the people getting the immune therapy, 50%. The 5-year survival rate for these people is 30-something%, right? We'd never seen anything like this before in lung cancer. But hopefully this is just the beginning. So when the patient signed up for this protocol, they were told, you'll get 2 years worth of this drug and then you'll stop, right? That seemed pretty reasonable at the time. We had never had a cancer drug that you could give for 2 straight years. So they said, well, you know, probably most people aren't going to finish 2 years worth of treatment. Lo and behold, that wasn't true. 35 patients of the 160 or so that got Keytruda finished the whole 2 years, and so they stopped. We didn't really know what was going to happen to them afterwards, but now enough time has gone by that we know. So these are swimmer plots, okay? And each horizontal line is an individual patient. The red is the 2 years of Keytruda that the patients got, and then the green is time off of Keytruda, right? And you can see at the bottom, months. It's funny just to see months down there. Often these graphs say weeks, because of how quickly cancer progresses. So seeing 60 months on the x-axis there is just astonishing in and of itself. And if you look at the patients in the red box, you can see the vast majority of them at the end of the green bar, there's nothing. That's because those patients are alive and well, and their cancer has not come back. Medical oncologists like me are very interested in what's going to happen to these patients. Are they cured? We don't know. But they're certainly closer to being cured than anyone that's ever had stage 4 lung cancer before. And like I said, this is 16 of the 160 that started. Now, it's not everybody, and at the bottom you can see that these are people that had their cancer come back when they stopped Keytruda, right? 4 of them responded again. They got started on Keytruda and their tumor started shrinking again. 6 of them, things were stable. 2 didn't respond, right? We're not satisfied with this arbitrary 2-year cut point. We need better science to understand why some people are in the top group, they can stop, and others can't. But this just goes to show you the potential and the promise of these drugs and why we as oncologists get so excited about giving them. This is the same study that was in people that didn't have high PD-L1 expressions, right? So a high PD-L1 is good. What if your PD-L1 is not high? You see the same thing. 24 of these 57 people that finished their 2 years, their cancer hasn't come back. And then one more time, in a different histology, that was in the adenocarcinoma patients. You see the same story with the squamous cell carcinomas. You really can't say enough about how remarkable this is. Nobody thought this was possible before these drugs existed. I've been in practice, I'm in year 6. I'm lucky enough to have patients that I met when I started, and I see them every 3 months with a scan, and they say, is my cancer coming back? And I say, I don't know. It's the best I can say. And you just look forward to seeing those patients on your schedule because you know that this represents where we can get to. So now we're here with our progression, right? We've got a club now. These are all the immune therapy drugs that are approved. You can see the different colors. They don't project very well, so I'll try to call them out. You have the orange, the furthest to the left. Those are the metastatic non-small cell lung cancer patients that didn't have any other options, right? So those were the first approvals. And then you see in 2016, Keynote-24, like we talked about, frontline metastatic. Then you see in 2017 and 18, new drugs approved. In 18 there at the bottom in the red, we have the Pacific study, that's stage 3 patients, giving them immune therapy, significantly improves their cure rate. Then you have in 2019, small cell lung cancer. Unfortunately, we haven't made as much progress in that disease. Definitely an unmet need, but we did show that adding immune therapy to chemotherapy helped those patients. Saw the same thing in another study in 2020. And then we started saying, well, what about people who have surgically resectable lung cancer? Can they benefit from immune therapy, and how? And the short answer is yes. That yellow box, that's for immune therapy after surgery. And then the green box, that Checkmate 816, is for chemotherapy and immune therapy before surgery. So as you can see, as time's gone by, we've gotten better at identifying the right types of patients, the ones that can benefit from these treatments. But as you can see at the bottom, we're not there yet. Where are we going from here? This is the cancer immune cycle, right? In order for a cancer cell to kill, for an immune cell to kill a cancer cell, it has to recognize that the cancer cell is bad, right? That typically is through the step 2, the antigen presentation, right? An antigen is a cell particle, and the immune cells need to look at an antigen and say, you're from a cell that shouldn't be here, right? Then that immune cell needs to get activated. It needs to find its way through the blood to the tumor. It has to then find the cancer cell itself, recognize it, and then it has to kill it, right? And this happens in a cyclical way. And so the idea is if we can get this wheel turning with medicines, whatever it is we can do, that's why people can go into sustained remission, because then their immune system does the job for us. We don't have to keep doing it for them, right? Now the drugs, you can see step 7, that's where Keytruda, Opdivo, et cetera, are. For some people, they're enough, but it's not enough for everybody. And we need to better understand scientifically why some people respond to these drugs and why some don't. We need to look at each individual patient's cancer immune cycle and figure out where the deficiency is, and then customize what therapy we're giving in order to get this cycle turning in the direction of an immune versus cancer response. CAR T therapy, TIL therapy, some of you have heard of this, maybe not. This is going to sound like science fiction, and it sounded like it to me too, but it's not. We know that we can scientifically engineer, change cells to get them to do what we want them to do. CAR T cells were the first that we were able to do this in successfully, primarily in blood cancers, but now solid organ tumors are catching up. TIL therapy is something that has a lot of promise, but still a lot of pitfalls as well. The idea is that inside any individual tumor, if you remove a tumor from a patient, there will be T cells there. They have found the cancer, right? But there might not be enough of them, or there might be something going on in the tumor where the tumor is winning the battle, right? But those T cells are inherently good. they got to where they needed to get to. They just couldn't get the job done. So the theory is that, well, what if you took those T cells out of a patient and then expanded them by a factor of 1 billion and then reinfused them back into the patient? They already have a built-in homing beacon. They know what a cancer cell looks like. What would happen if we did that? And lo and behold, in melanoma, we are doing that successfully. There are trials in lung cancer investigating this, cervical cancer, head and neck cancer. We're making progress. We're not where we need to get to, but our ability to either understand the genetic underpinnings of each individual person's cancer or understand a person's immune system and how it will interact with their lung cancer, I truly believe that the sky's the limit. And like I said, I feel very fortunate that my patients can all benefit from this. Other tumor types, we haven't made as much progress. We're not giving up. But in the lung cancer world, this is not science fiction. These targeted therapies and immune therapies are happening in clinic every day. And it's really been a joy to be a part of it all.